this first IPC Journal Club hosted by IPC partners. Pleasure for myself, Phil and John, to welcome you to this first Journal Club. We've already pre-picked the paper, which John is going to run through and give his thoughts. I'm just about to post a little message which tells you a little bit more about IPC partners. The plan is to hopefully run this every couple of weeks. So we really hope you enjoy this and it becomes a regular thing. But before John gets into the paper, I'm just going to give you a little bit of an introduction about what our kind of aims are for the Journal Club. Ultimately, the purpose of us speaking is to give you an insight into a topical IPC published paper, probably which has been published really recently. And what we'd really love to do is generate a bit of discussion. So we'd really like to hear the engagement from you guys who are listening in the audience about your thoughts with the paper. So we're going to be taking questions at the end of this. And I guess the first bit of housekeeping is to use the Q&A, which you can see at the top of your screen, not the chat box for questions, if you can. And John has also posted a poll in the chat. You might have to scroll to the top of the chat to get access to it, but that poll is just to get some insight on your, maybe if you've read the paper previously, but just to generate a bit of thought around this paper. We want to ultimately provide opportunities for critical thinking and continuous professional development, build confidence for independent study as well. So use this as a way which people who are in infection control, interested in infection control, want to get into infection control, can learn more about something which is topical and relevant. And ultimately, we'd love to build a network of enthusiasts. John and I have been overwhelmed by the positive response and just how many people have registered for this. We've got over 100 people who've joined us already. So we'd love to be able to create a bit of a network about people who share a common interest in infection control. And we'd also like to have a bit of fun while we do it as well. So that's just a little bit about the purpose of what the Journal Club is designed to do. Like I said, there's a bit of an information in the chat about who IPC partners are, and we'll be sharing a bit of information at the end of this about our next Journal Club, which we've already got planned in for 2 weeks' time. But without further ado, I'm going to pass over to John. John is going to give a bit of an introduction, and then he's going to delve into his thoughts and kick off the Journal Club. So over to you, John.
Thanks, Phil. Good afternoon, everyone. Thanks for joining. I know things are so busy and there's always a million things going on and conflicting priorities all over the place. So I'm very grateful that you were able to join us today. My name's John. My day job is Director of IPC at Guy's and St Thomas's in London. I can see on the list of people who've joined us today some friends and some colleagues from all over the country. It's also quite exciting that we have people from all over the world joining us today. So that is great. So we've got over 100 on the call today, quite a few registered online as well. So the recording will be made available after the event, and without further ado, let's jump in to our paper for today. So Pseudomonas aeruginosa is a really common infection. It's important in many of our clinical areas, particularly within critical care. There's compelling evidence that wastewater, and exactly what we mean by wastewater is something we can discuss. But particularly sinks and drains are involved in the transmission dynamics of Pseudomonas and other bacteria in hospitals. But the truth is it's difficult to know exactly how much and in what way wastewater contributes to transmission. So that's why I thought this article was quite interesting. So it's a nicely designed prospective study in 6 Canadian ICUs that was run for 10 months between 2018 and 2019. One of these ICUs was burns, one of them was, and 5 from medical. Interestingly, and probably if you're working in the UK, in contrast to your setting, 4 out of 6 of these ICUs had 100% single rooms. So it is quite a different setting to many of us are used to working in. It involved the whole genome sequencing of Pseudomonas aeruginosa clinical isolates, screens, and environmental samples which were collected from sinks and sink surfaces in the air. They defined sink to patient transmission as an ICU-acquired Pseudomonas aeruginosa isolate with a close genetic relationship to an isolate previously recovered from a sink in a room or bed space occupied 3 or 14 days prior to the collection date of the relevant patient specimen. Sorry, I know that's a bit of a mouthful, but it's just important to go through that in a bit of detail to set the scene for the results that they found. So what did they find? So of their just over 4,000 admissions, 60 of these met the surveillance definition for a Pseudomonas acquired healthcare associated infection on the unit. So around 1/3 of these were colonized on admission, around half were not colonized, and the rest had an unknown colonization status. It's difficult to know whether or not they were colonized beforehand. One slightly confusing aspect of the study that took me a read or two to get my head around was the fact that they had a similar number of acquisitions of Pseudomonas aeruginosa as they did of healthcare-associated infections. So, of course, an acquisition of Pseudomonas is not the same as an infection with Pseudomonas. But overall, if you sort of crunch the numbers, around half of the Pseudomonas healthcare-associated infection originated from Pseudomonas that appeared to be acquired on the unit, not accounting for the fact that some had a colonization status that was unknown at the time of admission. Unsurprisingly, and very much in line with other studies, Pseudomonas aeruginosa was associated with a longer stay and contributed to death in quite a high proportion of these cases, around about 1/3 of those with Pseudomonas aeruginosa. Healthcare-associated infection died to an extent from their infection, although maybe not directly attributable. So kind of the key nub of the study, and if I'm just going to scroll back and have a look at the poll right at the top here, looks like only one person has submitted a vote. I don't know whether that's an issue with the voting system, but if you could just have a look at this poll, there was a question right at the top. So good to take feedback on whether that worked for you or not. But the findings in this study is that 4 patients with 5 separate infections, so that's 7% of the overall number of admissions, had closely related isolates that were linked to their room or bed space in the environment. So these looked like the sink drain associated Pseudomonas infections. One thing that came out in their analysis of the data was that one of the variables they looked at to see whether it is associated with Pseudomonas healthcare-associated infection was the number of water sources per room. And what they found was that was not significantly associated with Pseudomonas infection, whereas other studies have found that does seem to correlate. So that was a surprising finding. So what about some sort of critical analysis of this paper, and where does it leave us? Well, I think by the admission of the authors, the number or the rate of sink associated Pseudomonas aeruginosa infections was probably underestimated, and that's for a number of reasons. Perhaps the most important is if you actually look at the number of environmental sampling episodes that they had during this study. It seems that they only had 7 rounds of sampling over the 10-month study. And reading some of the detail of the study, only 4 of those rounds occurred during the patient data collection window. So that means that if they're only having a cutoff of 3 to 14 days in their definition of sink acquired, there'd be quite a lot of actual sink acquired infections that were not linked to the subsequent patient isolate, because a round of environmental sampling didn't happen to coincide with when the infection occurred. Another factor is that only around 60% of the sinks on the unit were sampled at all. So you had about 40% of the sinks that were on the unit that didn't get environmentally sampled at all. So there's quite a big environmental reservoir there that's not being picked up to be linked with subsequent patient isolates. They included air samples as part of their sink when linking sinks to subsequent Pseudomonas healthcare-associated infection. I couldn't work out what proportion of the ones that were linked were air-related. Perhaps that was in the paper and I missed that. But it was an interesting strategy to include air as part of the sink. I mean, I get it, because we know that probably the main mechanism by which organisms that are stuck down in the drain of a sink get back up to the patient care area is via the air, via splash, and possibly some aerosol as well. There's always going to be issues with the sensitivity of the sampling methods that we use, particularly environmental sampling methods. As I mentioned, not all sinks and drains were sampled. And as Phil and I recently put our heads together and wrote a letter to JHI, which part of the sink do we sample anyway? It looks like on this occasion they sampled only the surface of the sink and some of the surface of the internal pipework. But what about the water that's in the trap? And what about a wider sample from the sink and the sink mechanism as well? There's some questions over the sensitivity of the emission screening program, which is crucial when we're making inferences about acquisition. How sure can we be that the patients who arrived were or were not colonized? They used a variety of methods, and it looks like some discarded swabs that they went back to do some microbiology on. So definitely some questions over the sensitivity of the emission screening and looking at the whole genome sequencing and the genomics. What is the best cutoff to say, yeah, this isolate is the same, this isolate is different? They used I think, actually I can't remember, maybe a 20 single nucleotide polymorphism or variant cutoff, which is standard, but it's quite difficult to know. And do we need to think slightly differently about environmental isolates? Because it may be that the molecular clock ticks at a different speed for organisms that are sitting there in the environment as compared with organisms that are in patients. So finally, what does this mean for IPC? And I'm going to try and keep to 15 minutes because I really want to see what everybody else thinks about this paper and have some discussion. So this is just an introduction, really. Well, it certainly reinforces this idea, this important idea that sinks can be an important source of ICU-acquired Pseudomonas aeruginosa infection. Definitely underlines the clinical impact of Pseudomonas infection in this ICU setting with a third of patients having some degree of attributable mortality. But it also raises questions about how far we have to go in our understanding of the transmission of Pseudomonas and other organisms from wastewater. It's still not clear to me, how do we sample the environment with optimized methods? How do we even interpret the genotyping data? I think there's some questions and uncertainty there. And how do we factor in the undetected reservoirs as we try to piece it together and work out our transmission our transmission dynamics? So we know from other studies that if we were to be so brave and so bold as to remove sinks and drains from an ICU setting, there's a couple of really powerful studies now that suggest that can help to reduce the risk of healthcare-associated infection, particularly with the antibiotic-resistant gram-negative pathogens. Does this study provide more evidence that we should go down that route? I think it probably does, but it is a bit of a shame that they probably underestimated the number of ICU-acquired Pseudomonas infections linked to sinks due to the way that the study was configured. So overall, it's a great study, certainly prompted some discussion in my head, and I hope it raised some questions for you too. So Phil, back to you, and let's see what's happening in the Q&A.
Thanks, John. We got the poll working eventually, and we had 90 responses. So I just ended up reposting it. 71% said the correct answer, which was 7%. So I don't know if that's because you'd already flashed up the answer or because they read the paper. I was going to say,
hang on a minute.
Yeah.
That's because they were listening, because I'd already said it.
Yeah, so good that they were listening anyway. Yeah, so a question here from Kerry. Kerry asks, is Pseudomonas aeruginosa coming from biofilm from the drain, or is it coming from biofilm from the water coming from the tap? And also asks about how often is water tested in facilities.
So we don't know from this study. So they took a sample from surfaces of the sink, from some of the pipe work in the drain, and also some aspect of the tap. Your point is completely valid. Pseudomonas we know can contaminate the tap, it can contaminate the sink, and it can contaminate the drain. So because they sampled them all at the same time, it's not possible for us to tell where they were coming from in this one. Usually in the UK, in a critical care setting and in other augmented care settings, there's a program of routine testing for Pseudomonas. And when Pseudomonas is found in sinks and drains, the estates team goes to work and starts scrubbing away to try and remove the Pseudomonas reservoirs. If the levels are really high, point of use filters are quite often used. And there's some guidance in the HTM on what that testing program should look like. I'll see if I can dig it out and put it in the chat.
Great. Another question kind of building on from that, I guess, John, is we're seeing more and more people now taking notice of sinks and the role that they might play in the transmission of infections. And we're using a lot of people using, whole genome sequencing as well as swabbing to identify the different organisms are there. And I guess the question is it actually achievable to implement whole genome sequencing on a regular basis to keep an eye on what might be lurking in those sinks? Or are we only ever going to be in a situation where we can employ it when we've got an outbreak and we're trying to get to the bottom of that outbreak?
Well, I don't know the answer to that question, and in a way it feels a bit like the $1 million question at the moment, because I think we're on the cusp of getting pretty close. I certainly have a vision that we'd have an IPC service that's very informed by whole genome sequencing, so that every significant clinical isolate would be typed in the background. Maybe environmental isolates too, although perhaps the sort of health economics, the cost and the benefit analysis of doing lots of environmental samples via whole genome sequencing outside of an outbreak setting. I'm not sure anybody's even looked at that to see how they stack up. But I do see a future in the not too distant future where we will be sequencing an awful lot more just as a standard part of what we do. And then we can already have the sequenced isolates so that when we have possible cross-transmission, we can say yes or no. And that way we can realize the benefits of that additional insight. Because if it's all done retrospectively 2 weeks down the line, you're not going to be opening and closing bays based on the results.
Yeah. And maybe just to build on that, have you got a view on who would have the responsibility, for ensuring that's done at the right frequency? Who actually goes and takes the samples? Is the sampling and the testing done in-house? You and I have talked about it in previous publications around the complexity there is with sampling, but I'm just trying and break into, how can we think about trying to adopt something which we think has got a lot of promise, but ensure that it gets embedded within organizations and within practice. Where does the responsibility lie? Do we need investment in more staff? Do we need specialist staff to do this type of work? What do you think?
Yeah, I think the work that's done, the environmental samples that are generally taken at the moment for Pseudomonas in critical care, usually they're outsourced to companies that specialize in that kind of thing. They wouldn't often go through hospital labs, although maybe there are some hospital labs that take on that kind of work. And that model seems to work okay. I suppose if it was to become much more embedded in what we do, more routine environmental samples, then it might have to come in-house, which I think is doable. A hospital lab would have the expertise. It's just whether the costs stack up really of doing that routine environmental sampling. We've certainly moved away from routine environmental sampling of hard surfaces in healthcare, and I think the focus has been much more on getting the disinfection right. So there's almost an assumption that you have contamination of the surface and you just need to get your process right to disinfect it. So perhaps similar logic might be taken with interventions that we might take to disinfect, say, a drain in a critical care unit like these ones.
Great. The questions are flying in now, John. Just to remind people, there's a Q&A button that you can find in your menu if you'd like to ask a question. Next question, John. What are your thoughts on transmission pathway? Is it patient to sink or sink to patient?
Difficult one to answer that without magically tracking the Pseudomonas and watching it spread in real time, which clearly we can't do, but I'd love to do. I mean, the study design was configured to try and answer that question. So they said you have to qualify for a sink-associated Pseudomonas infection, you have to have had your environmental sample positive before you were in that space. You had to come in without Pseudomonas and acquire the same strain of Pseudomonas seemingly from the environment. I guess the challenge to that might be, whilst it looks like sink to patient, it could actually have been patient to sink because of limitations with the admission screening or the sensitivity of the patient admission screen. So the timeline might get out of sync that way. But the study was configured to say that. So I think we can say with fair assurance that these 7% really do look like sink to patient and not patient to sink.
This is a tough one. How rigorous was the attribution of mortality? And that's from Neil.
Yeah, it's a good question. So I forget how many patients actually. I think they had a measure of sort of direct and indirect attribution of mortality. This was done in Spain, I think it was, not in the UK, so they wouldn't have had the same medical death certificate system that we have and that many in the UK are familiar with. But it sounded similar. They had sort of a directly attributable or an indirectly attributable. And I can't remember now what the proportion was of those two.
This is an interesting one, John, talking about water-free care. So our ICU colleagues currently use water-free warmed wash wipes to provide patient hand hygiene. The team are reviewing wipes as part of a sustainability project, and I've asked the question if they can move back to washing patients with tap water. I'd appreciate your thoughts.
So just make sure I've got that right. So they're using hand wipes these patient
wash
bathing.
wash wipes for patient hygiene. This is patient hygiene.
General patient bathing. Yeah, it's a really tricky one, isn't it? Because I'd love to say we should stick to the single-use wash wipes because I'm sure they're safe. If you look at some of the data on wash bowl contamination, it can be really quite alarming what sort of organisms you find there. I think in theory it ought to be able to be done without the single-use patient bathing wipes, but I think the reality is that's likely to be a safer and better approach. So that there is a tension there between a sustainability agenda and an IPC agenda that we need to work through.
Yeah, there's quite a lot of discussion going on now, which is great to see. And there's a kind of question about minimizing use of water and whether or not it's an option. It's something that I'm reading a lot about now, about intensive care units and high dependency units implementing water-free care. I heard recently the expression water light, which I like a little bit better because, you know, water-free obviously implies that there is no water and we rely on water so much within healthcare. But yeah, what's your thoughts, John, on kind of reducing use of water to prevent infections?
Yeah, I like water light. It's a good way of putting it because it's not entirely water-free. It can't be entirely water-free. We did go through a process in a previous role in a neonatal setting where we had serious issues with a small number of water outlets. We just could not get rid of the Pseudomonas. So we did decide to go water-free in a bay in a neonatal ICU for a short period of time. That was a really good experience to go through because we got to get around a table with the frontline clinical teams to say, okay, we're going to try and not use tap water. What do you use tap water for? And all these things came out of the woodwork that they were using tap water for that we hadn't really clocked before. And what were the alternatives for each thing? So it's not straightforward, and it does take real collaboration and good old-fashioned MDT working to nail down how you're going to work around it safely. But it is doable.
Mm-hmm. You know, somebody said, if we remove water-free, if we go water-free, how do people wash their hands? And I think in the studies that I've read, there are sinks there for hand hygiene because obviously it's so critical. And I think ultimately it's about trying to reduce the sinks that are placed in the clinical environment where there might be more risk to vulnerable patients. And I think, again, the studies that I've read are talking about removing or reducing water usage where there is more risk in your high vulnerable or intensive care patients.
So maybe it doesn't necessarily have to be all or nothing. So
yes.
maybe we could follow a reduction strategy or at least a reallocation sort of strategy.
Yeah, definitely. You know, there's some interesting comments around obviously water light might increase the use of consumables as well. And in an environment where sustainability is so important, with the challenges around it, the climate challenge and sustainability agenda, obviously if you're introducing more consumables and things like wipes, it really adds to the waste stream, doesn't it? So that's another challenge where we're always trying to get this balance right between patient safety and also now things like sustainability, isn't it?
Yeah, it's a really fine balance, because obviously spreading organisms that cause infection isn't good for sustainability either. So if we have to spend some consumables to reduce transmission and prevent healthcare associated infection, that probably does work out and balance out as a net gain.
Mm-hmm.
But if we end up spending tons and tons of consumables to prevent one healthcare associated infection, it probably doesn't stack up anymore.
Yeah. This is a great question, John. And it says, would you recommend that infection prevention control nurses go on a water safety or water management course?
Yeah, I would. I would. I think that would be really valuable. And I'm not sure which one would be best, because some of them are very long and very expensive. Perhaps we need a bit of a middle ground of courses that are configured for infection preventionists who are working day to day in the ward, don't necessarily need to know chapter and verse of everything, but actually just improve awareness of worked knowledge of risks related to water and how they can be managed. Definitely.
Yeah, great. People are even sharing resources in the chat now, which is great to see. So people are sharing other papers. So I encourage you all to maybe have a look at the chat to see if there's stuff that might be relevant to you. I'm going to take two more questions, and then we're going to wrap it up because we want to stick to time, and we want to tell you about the next journal club as well. So why not just more, in brackets, focus on IPC measurements like hand hygiene, cleaning and disinfection, and keeping the environment clean instead of sampling and whole genome sequencing? That's quite a tough one to answer.
Yeah, so if implementing prospective whole genome sequence is going to cost me, I don't know, let's pick a number, £100,000 a year, how many full-time nurses and how many orders would that buy me? And how do we balance those two off? I don't really know the answer to that question. I suppose it's one for health economic modelling. That's meant to be the point, where we can use a sort of incubator environment to test various interventions and various permutations of intervention to work out which is best, all things considered. But I do think that investment in innovation and new approaches is something we should be absolutely open to, provided they stack up, they're evidence-based, etc.
Yeah, definitely. I've been speaking at the IPS West Midlands today, and we've talked about, the importance of innovation and partnering with industry to ensure that there are new innovation projects going in to tackling things like biofilms in sinks and drains, and also on surfaces as well. So yeah, there's been some great resources shared in the chat, and I think this is quite a nice one to finish on, John. How do you envisage the implementation of water light practice in a single bedded intensive care unit? So ultimately, what do you think that looks like in practice?
Not immediate. It will take a bit of time. There will need to be a lead in time. There will be resistance, definitely, from staff within and without IPC. Some people in IPC will feel very strongly that we need to retain sinks, for example, for hand washing, whereas others will be more comfortable with moving over to wipes and accepting of that evidence. And you'll have that same difference of opinion outside of IPC as well. And as I mentioned earlier, it's about sitting down and thinking in straight lines about why we use water, when we use water, and how we can circumvent the need for tap water. So it's doable, but it's a journey.
Right. Thanks, John. So we're coming to time, and there's a little bit more information here about the next IPC Journal Club. Thank you, everybody, for attending. I think we peaked at 187 people online, which is really great considering this is the first one. And it's really nice to see, all the conversation that's going on in the chat, and all of the questions that were coming in as well. So thanks, John, for leading us through that paper. We've planned and we've already chosen our next paper. So I'm going to post a link to the event now in the chat, which will give you all of this information. So there'll be a registration link there. which talks about the paper, which you can access. And a couple of people are asking if the paper was distributed prior, and there is a link in the invite, or the registration, I should say. So you can see the paper, which I'm going to be taking you through in 2 weeks' time. Jon and I are trying to keep a regular slot, so it's something potentially that you can earmark in your diaries. So we'll be at 3 and 3:30, and you can register on that link in the chat. We're also keen bloggers, so you can see a blog on this paper on reflections on IPC. And again, there are lots of resources that you can see if you follow Jon and I on X or Twitter, or LinkedIn. We're always sharing information around these articles and links to blogs, etc. And if you are interested in finding out more information about IPC partners, then you can please contact us on that email address below. But yeah, I'll just pass to Jon for any final comments.
Yeah, so I've put another poll in the chat just in terms of the duration. We couldn't really decide how long this should be, so we'll take a view based on the feedback we get. Thank you. I'll try and find a way to share the slides in the chat after the webinar's finished, and the recording will be made available to the participants, everyone who's registered, sometime afterwards.
Great. Thanks very much, Jon, and thank you all for listening.
Thanks, everyone. Bye.
Bye. Bye-bye.